Welcome to Airway Answers, expanding your breadth of knowledge. My name is Nicole Goldfarb, and I'm a speech-language pathologist and certified orofacial myologist. And I'm here to help you find your airway answers. We're in this together. Let's do this. Let's do this. Hello. I'm so excited. I am here with Joy Moeller. It's a joy to be here with Joy. I am so excited to have you on. Thank you for being here, Joy.
Anytime for you, Nicole.
So I'm sure everybody knows who Joy Moeller is, but I'm going to give your introduction. And I think you have the best name. It was like destined. It was fate that you would be a dental hygienist, right? We got to talk about how your name is Joy Moeller. So let's talk about a little bit about who you are. And we have some great conversations coming up. So Joy is a dental hygienist, author, and formerly an associate professor at Indiana University. And she has worked as a myofunctional therapist for many years and currently has a private practice in Pacific Palisades, California. Joy is founding lecturer with the Academy of Orofacial Myofunctional Therapy, the AOMT, which I'm sure everyone is familiar with, and a founding board member with the AAMS. She has taught postgraduate courses in myofunctional therapy at universities and hospitals worldwide. Joy wrote a chapter in sleep medicine clinics, a chapter in sleep disorders in pediatric dentistry, a chapter in management of obstructive sleep apnea, a textbook for oral surgeons in 2021, and a children's book on tongue positioning, as well as many published studies and other chapters and textbooks. And you just recently came out with another book. Can you say the title of that book?
Oh, Is Your Tongue Killing You?
Is your tongue killing you? How morbid. No, so great, though. I have that book. I should have brought it next to me right now. Is your tongue killing you? Everybody get this on Amazon. We're going to talk about this book today as well. I'm sure everybody's seen this. All the conferences I've been to, everybody's got that book. So a little bit more about Joy. We all know Joy lectures all the time. You've lectured worldwide. You were invited to speak at grand rounds at the Mayo Clinic in Rochester, Minnesota, to Stanford Sleep Residency Program. And you were the first myofunctional therapist to be on staff at the Pankey Institute. Joy currently teaches with the Palo Alto School of Sleep Medicine and has taught for 7 years with UCLA Dental Sleep Postgraduate Program and the Pedo Ortho Residency. Joy received a Lifetime Achievement Award from the AAPMD, the American Academy of Physiologic Medicine and Dentistry. That's where I got to see you most recently. And the Louis Pasteur Award from the AAMS in Rome in 2013, and the Richard Barrett Achievement Award in 2023 from the IAOM. You must be just so proud of yourself. I mean, you have made such an impact on the field, really breakthroughs in all that you've done. And I want everyone to be aware of just who you are and all you've done. So thank you again, Joy, for being here.
That sounds really good.
It sounds good, right? You are good. Well, I want to talk about, I know we had a little conversation yesterday too about different things about potentially you working with the American Medical Association, trying to get tongue as a specialty area in medicine. I mean, making huge breakthroughs. So let's back up and talk about first how you got started in dental hygiene, and then how you got interested in myofunctional therapy, because I'm sure those didn't happen at the same time. So let's hear about that.
Well, my mother was kind of she had a tooth fetish, she was always like concerned about her teeth, and she would save money. So she had extra money for the dentist, and we had to take meticulous care of our teeth. But I always had problems with teeth because of airway problems. Besides starting out, I couldn't breathe, and I slept on one side, and so I had a crossbite and a deviated septum. And, through the years of working closely with my dentist, I'll never forget him. He would give us a big all-day sucker at the end of the appointment after he drilled on my teeth. And nobody mentioned too much about sugar. As a matter of fact, I remember after I was a good girl getting an all-day sucker from the dentist and going downstairs. So there was a Walgreens underneath. And my mother said, you can have a sundae or a soda, whatever you want, So it would be more sugar. And I grew up with a lot of sugar all the time. My dad would bring Fannie Mae candy home. And my teeth were a mess, even though I brushed and flossed. And I had a lot of problems. I had puberty gingivitis where they did a full gingivectomy, gingivoplasty with no anesthetic. So
Gosh.
I became very fearful of the dentist. And I became a dental hygienist because I was always pretty smart in school. I didn't want to be a dentist, but I thought I'll prevent problems and become a hygienist. So, and I lived in Flossmoor, Illinois, and my name was Joy Moeller.
That's so okay. Let me repeat this. You lived in Flossmoor, Illinois. Your name was Joy Moeller. There are signs everywhere what you need to do in life at this point, right? That's so funny.
After I became a hygienist, I started teaching at Indiana University in the dental hygiene department. And I always wanted to be a teacher at first. I went to Northern Illinois University to be a teacher, but then I had 2 kids and I thought, no, I want to teach adults, or older people, and enough with kids. I taught kindergarten through 6th grade for a while. I went back to school to become a dental hygienist. And I loved it. I loved dental hygiene. It was so much fun. And then my youngest son, developed airway issues that were very bad. He had his tonsils and adenoids out at 3, and they never did that. He was born colicky and to breech and turned in the canal and screamed for the first year, didn't sleep. And then he started having headaches. He called them his skull crushers.
Oh.
And he couldn't go to school because his head hurt. The nurse would call from Solana Vista, come and get your son. He's got another skull crusher. And he didn't eat anything. He was real small for his age. And his little face was pushed in. Anyway, we moved to California after I had taken him to every doctor in the Chicago area, including Mayo Clinic at that time. They wanted to do surgery on his brain. And then we got transferred to San Diego. And I started doing dental hygiene for a dentist who had taken a course in myofunctional therapy. And he said, before you do surgery, let me take a look at him. And he said, his tongue is in the wrong place. I said, what? Never heard of such a thing. He said, yeah, it's supposed to be up in the palate and it's down and forward. So he gave me exercises to do and had me see Viola Fryman, who was an osteopath. And he made a little appliance to widen his arch. Within 3 weeks, his headache stopped. And then he started eating 2 meals at a time. And he was real small for his age. And he grew like 6 inches in a year and a half. And I thought, well, I have to learn this. So at the time, the only school to go to was Dan Garliner in Florida. That was 44 years ago, a long time. And I came back and I worked in 3 ortho offices. I worked in a TMJ practice. I worked in an ENT office and a chiropractor's office. And I had a little wheelie cart and would go. And everybody in San Diego knew me at the time. That was a long time ago. And then both my kids grew up and moved to LA, and 9/11 hit. So that's when I moved to Pacific Palisades. And I've been practicing here. I had my own office ever since. So,
which is a lovely area also.
Yeah.
Been in really great places.
Yeah. My son Actually, he went on to be a model
Oh, and look at that.
and an actor.
Oh
Yeah,
my gosh, look at that.
yeah, he's very handsome.
Yeah. Well, so how crazy. 44 years ago, all of this happened with your son. And it's like, we've come so far, but have we come so far? Because there are so many children still suffering with similar stories. I'm like getting the chills because it's so crazy how so much of these airway issues we know are undiagnosed. All these kids with medication, ADHD, anxiety, depression, skull crushing headaches, right? All these issues. And I think nobody knows that the tongue is like the stem or of the a lot of these problems. It's breathing and facial development. It's like it's crazy.
And my hat's off to you for having this podcast and get the information out there.
People
Because,
need to know. And you know what I do is I send these to the pediatrician and like the school where my kids go to. I'm like, share with the psychologist. I send these to them. I don't know if they listen, but people need to know, and all the work that we all are doing is helping spread this message. And of course, all that you do with all of your teaching, all of your lectures, it's just the books you write, the articles. If we can we talk a little bit about how your treatments changed? You're a myofunctional therapist. We understand how that got started now, helping your son and the changes you saw almost immediately. It sounds like 3 weeks, and you
yeah,
saw significant changes because he could breathe and sleep it better. How has your work in the field Yeah, go ahead.
his teeth, 3 months after we started this whole treatment, he went from having this crowded little mouth to beautiful
Do you
smile.
remember what kind of treatment? Because 44 years ago, what did they use? Was it a rapid palatal expander?
It was some kind of an appliance that
Yeah.
would widen. It was some kind of an expander.
Yeah.
It was different because he was a TMJ specialist. So
Yeah.
he
Well,
looked,
bless that doctor for even thinking outside the box, because I wonder how many pediatric patients he even saw, right? You wouldn't think back then a TMJ doctor would see many pediatric patients and
oh
think
yeah,
that.
he
What
saw a lot of patients. He's
and has
actually still alive. He's turning 90.
uh,
Next week, they're having a big party for him. He lives in Leucadia.
okay. So you stay connected with him?
Oh yeah, he's
Yeah.
like a brother to me. Yeah.
Amazing.
And his daughter is a myofunctional therapist,
Thank
Kathy Winslow. She's
Oh, I know her.
in the Bay
Okay.
Area. Yeah.
I didn't realize that. How amazing is that? That connection. That's just so profound because do they even know what kind of brain surgery they were planning on doing? Just exploratory?
Well, I found out later, at that time when people suffered from severe headache pain, they would do it was called an exploratory procedure where they would go in through the orbit and move the eye and then somehow do something to it was really scary. And I
Man.
tried everything. I took 2 speech therapy and occupational. I don't think there was occupational therapy back then, but there was a lot of physical therapy. I took him to many, many doctors, that ear, nose, and throat doctor, and pulmonologist, nutritionist. We went to psychologists. I took him everywhere, and he just wasn't getting better. He wasn't sleeping at all, and he had ADHD. And they put him on so many medications that he developed bleeding ulcers when he was like 11.
It's like that sort of spiral when one system is affected, everything else just kind of catapults because if you're not breathing well, you're not sleeping well. If you're not sleeping well, hormones are off, everything is off. You're not eating well, then you're not feeling good, and then the medication, it's like everything compounds. And if we can just get to the root cause, we can save so much suffering, right?
But I don't think the profession is going to go anywhere until we actually have a specialty in medicine
Let's
that
talk about that.
deals with the tongue. especially the back of the tongue, because the back of the tongue is actually a respiratory organ.
Mm-hmm.
It works with the diaphragm to bring more air into the body. And if the back of the tongue is not functioning, which is many, many children, even if they have their tongue released at birth. I just watched a video from the doctor, the ENT, and
Dr. Gahary.
yeah,
I know, I just watched that. I shared that.
That's so true. They baby get their anterior part released at birth, but the posterior is still attached. And that's why I see most of my patients now have a posterior tie.
Yeah, that mid portion of the tongue, if it can't easily elevate, if it can't elevate sufficiently the mid, and that gets missed a lot where they're just releasing the anterior, and we see that in a lot of babies. I have a lot of pediatric patients where maybe a 10, 11, 12-year-old, and the parent's like, oh, he had a tongue tie release at birth. And I'm like, oh, it's still restricted.
We've done that already.
Yeah, you're like, actually, not really. But yeah, the back of the tongue is a respiratory organ. I like that. I like thinking of it that way. So what do you foresee with like a medical specialty of disorders of the tongue? What would that be like?
Well, I think they would take responsibility for all the aspects, everything, and then refer the patient to the physical therapist or the speech pathologist or the dental hygienist, who's ever doing myofunctional therapy and understands all of the aspects.
Mm-hmm.
I think also they probably would do the frenectomies and tonsils and adenoids and everything related. They would refer to that specialist. But I think more than anything, what I've seen is if the back of the tongue is functioning, the brain is functioning differently. There's a neurologic component, and I've seen so many kids with tics and problems like that are solved with myofunctional therapy.
Can you talk about some of those cases? I remember you presented on a case where the child had Tourette's and significant tics. Can you talk about that?
Yeah, well, my feeling is I'm a dental hygienist. I'm not a doctor, but the back of the tongue and the mid portion of the tongue, if it's functioning correctly, not only is it helping you breathe better, but it's stabilizing the brain. And I really feel that cranial nerves are up there, and if the tongue is working correctly, there's more stability for the whole body. As we know, the tongue is the rudder for the spine, and it's connected all the way to your feet, but it's also connected to the cranial nerves in the brain. And I don't think people understand that. I'm treating 2 neuropsychiatrists right now who want me to speak to their international group. So I think I'm going to get Samantha to do that. But oh my gosh, there's so many things. I mean, they're blown away. They both have sleep apnea. One I just sent to have the tori removed, and she, for the first time, her tongue is functioning. Mm-hmm. She feels like $1 million. And I mean, there's so many things they don't know about what the function of all the head and neck muscles can do for the whole body. Like every aspect of healthcare is affected by the tongue. Mm-hmm. It does so many things to stabilize. I treated patients that have been diagnosed with Tourette's or diagnosed with autism, and they have movement disorders, or people that have had like Bell's palsy and have taken all the drugs and they still have the muscles that are collapsed on one side. And after you work with them, it comes back because the tongue is doing something. It's not just the face muscles, it's the tongue It's doing something to stabilize the cranial nerves.
Mm-hmm.
The vagus nerve is connected to every single organ in your body, and giving swallowing corrective and replacement of the tongue. And I really feel it goes back to the fact that nobody is breastfed long enough. And even if they are breastfed for 3 years, maybe for that patient, they need to go further because they have allergies, they have other effects. And then you add to it what I feel eventually they're going to find the micro nanoplastics, which is causing the tongue to be not as flexible as it should be. There's something that's tightening everything up.
Wait, what do you mean about the plastics? Because I just interviewed with Dr. David McIntosh, ENT, and he talked about that as well as a potential contributing factor to allergies starting at younger ages. It's a theory. So can you elaborate on that?
Well, I know recently they just found micro nanoplastics in the brain. You figure, if it can get into the brain, it's real easy to jump into fascial tissue. It's all over your body. And why are people feeling like tight if they don't do yoga or Pilates or stretching all the time? When I was young, we built muscles, but we didn't do as much stretching. And now people like even myself, I'm addicted to Pilates. It just feels so good.
Mm-hmm.
So why is it that it feels so good to stretch? Got to think about what is tightening everything. So if you stretch on Tuesday, you want to go back on Saturday and do it again.
Mm-hmm.
And so I'm just curious. I started looking at the research on micronanoplastics. I found there's even journals on it. There's a lot of people interested in the damage from plastics. And it's not just in our food and drinking out of plastic bottles, but it's in our clothing. They put chemicals in our clothing, and then we wash it in the wash machine and wash it with the towels and the sheets, and it's everywhere.
It's overwhelming when you think about it. And as humans, we try to come up with better ways to do things, more efficient.
So that's bring back glass bottles. No.
Yeah. Oh no, don't look at the bottle I have next to me. But yeah, more efficient ways, but then we might be adding toxins into the environment, destroying the environment, and destroying our own health. So it's kind of overwhelming to think about that aspect, right?
It's very
wow.
So with all the chemicals they're putting in crops.
Do you feel like there's more myofunctional disorders? Like throughout your years of practice, has there been an increase in evidences of myofunctional disorders, and why do you think that would be increasing?
Well, it's a lack of breastfeeding.
Mm-hmm.
When I first started, very few people were tongue-tied. I might have seen one a year. And a lot of times it would just kind of stretch a little bit with therapy, and that was enough to get their teeth straight or get them out of headaches or TMJ pain. But now it's like almost every patient I see has some kind of restriction somewhere. And so the increase, I think it's a epigenetic kind of factor where we have your grandparents were breastfed or your great-grandparents were breastfed, but your parents weren't.
Mm-hmm.
And then they didn't do it to you, So there's like genetic factors that add into it as well. Nobody in the family was, everybody was bottle fed. I know when I had my sons, my mother said, "You're going to ruin your breasts. Stop it." My doctor said, look, your milk is watery, which was colostrum. I listened to them.
They didn't know. Imagine all the false information we've all received over the years and are still receiving.
Well, it's so much easier to bottle feed.
Right. Imagine that. Like all the false information we're told, it would be neat to have like a replay of our lives and things we're told and be like, like put like a buzzer every time a physician or somebody told you something that's incorrect and we thought to be truth. Because, there's so little that we really know. But we know that nursing is the catalyst for good orofacial growth and development. That is the beginning. There's so many other things that can go wrong, though. It's just interesting because you said, like, go further, right? So nobody's breastfed long enough, you feel like, is one of the big epigenetic factors. But we need to go further, like addressing allergies and other things. And it's interesting because a child could be breastfed for a long time, years. But then if they're given a pacifier, sucking bottles, sippy cups, they're a thumb sucker, any other things that could completely negate some of those positive impacts of nursing. So it's like we need
like
people
pouches.
to picture the sucking pouches. Oh my gosh. I bought those. I'm not going to lie. Those were easy.
Everybody's, it's organic, Joy. I don't care. It's dangerous. I said they're dangerous.
Well, I think that's where some of the confusion is. And same with bottle feeding. It's like if you're like, oh, well, it's breast milk, I'm pumping it. Or it's organic in the sucking pouches, but it's the mechanism that the muscles are being used or lack thereof that's the problem. So parents need to understand that aspect, not just like it's organic or it's actually breast milk, but the mechanism that's occurring, the way the structures and muscles are being used is what's important.
It's not just the breast milk or the muscles. There's other things. The neuropsychologist that I'm treating, or psychiatrist, she said, when you breastfeed, your eyes are looking at your baby's eyes.
Yes.
And that helps the baby's vision. I thought, whoa. That there's a big connection there with the baby's moving their eyes, looking at your eyes, and you're looking at him. They're fascinated by looking at your eyes, but it does something to prevent eye problems later.
Mm-hmm. Imagine that natural, and not every mother can breastfeed. We know that, but we still have to talk about what are the positive impacts and the negative impacts of those sucking pouches and sippy cups. And can you talk a little bit about that, sucking pouches, sippy cups?
Yeah, because when the spouts are in there, whether it be a pacifier or a bottle, baby bottle, or a thumb, or anything, your tongue has, I always say, 16 muscles inside of it. And if those muscles are not being used, when you have the spouts and all the things that people put in their mouth, and they're lacking that feeling of something on their palate, which is very comforting. Not only does it cause the natural expansion for the palate, but you also are receiving, I call it endorphins, because there's like a foramen in your palate where all of the nerves, arteries, veins, everything is running right up into your brain. And so it feels good to suck your thumb. And then you're shamed into not sucking, of course, or you put a rake in there or something by the orthodontist. That's what they're trained to do. And so you're always feeling like something's missing. So those are the patients, when they grow up, are going to look for something else to make them feel good. So they're going to turn to smoking because you're putting something else in your mouth. Or I've seen carpenters come in with holding a nail. They always hold a nail in their teeth. Or they're always like biting their nails or touching their face somehow because of missing those endorphins from not getting the comfort of having your tongue up there all the time. That's why myofunctional therapy is so exciting, because once the patient's tongue starts going up, they just feel better. And it's exciting to watch that unraveling. It's really, but even as well-trained as speech pathologists, hygienists, and physical therapists are, we still don't really have the core issue. And I think about what would a curriculum be for a physician specializing in the tongue. Well, they'd have to learn all about teeth and all about speech issues, and they'd have to learn all about how the whole body is functioning or not functioning because the tongue is not in the right place functioning. Mm-hmm. So they would support our work that you've done. How 15 years, 20? How long have you been?
Well, I've been a SLP since 2003, and then I took my first myofunctional therapy course with you in 2008 in Los Angeles.
Yeah.
So what is that? That's like 16 years of myofunctional therapy.
Yeah. So you've seen how it works with speech and how it helps.
Mm-hmm. Well, the funny thing is, your kids went to school in the district where I worked for 7 years at different times. They were there before I was there. But that's where I started getting interested in myofunctional therapies, because I had heard of it. It wasn't anything in our graduate program back then, but I saw so many kids for speech issues that I could see something wasn't right with the face, the tongue, the baggy eyes. So many kids that I misdiagnosed. I mean, I maybe treated one part of the issue, and I can literally picture faces and names of kids, almost like this guilt, where I missed something really big and important. But back then, I thought I need to learn about myofunctional therapy. I took your course and I still worked in the schools, and it changed everything, the way I did all my evaluations, all my treatment. And then I just branched off and started doing my own private practice at that time. But it really changed everything for me. And it's really important as SLPs to understand about myofunctional therapy, even if you might not be treating it a lot. And physicians, like what you're saying,
it has to come from the top down, though. That's why I'm getting all my patients who are physicians. I have a lot of patients that I've seen that are actual doctors, and they get that aha moment, but I'm getting them to write letters. And I'm trying to solicit the AMA to add this, because it's getting other doctors to say it's important. But it's been a passion of mine with dentists or dental hygiene programs. I was real active in the ADHA and all this. And at one point, I got asked to speak. There's a group that meets every year and has a convention where they're the heads of dental schools and dental hygiene schools. And they meet every year. And Colgate actually asked me to speak for 2 hours at this meeting at a luncheon that they were paying for the lunch, and they were sponsoring me to come and speak. And there were all these heads of schools that I was so excited. Finally, we're going to do this. Let's get it in the dental hygiene program or the dental school program. And it was interesting because the way they set it up was that I would talk for an hour and 15 minutes. And then the other time that was left, I could go from round table to round table while they were eating, discuss how to get this into their program. And I was so excited, but I was so depressed afterwards because they all said the same thing. We don't have time to teach instrumentation and, all the anatomy and all the things that they have to get done in order to pass the dental board or the dental hygiene board. And then they also all asked for my card because they had a cousin or a brother that was just diagnosed with sleep apnea. And here I am, saying, well, that's why I'm speaking, because I want you to, somebody has to take, there was no like leader that said you have to. And so it's now included in speech therapy as something you can't do with continuing education. But so many speech pathologists, they get out of school and maybe they want to do stroke, or maybe they want to do stuttering, or they might want to just work in the schools, and they don't have time to do a myofunctional program. So we need somebody at the top saying that this is necessary for health, not just dental health or orthodontics or speech, but for the whole body.
Yeah.
Because
it should be a necessary aspect of every curriculum, every medical curriculum, even if it's not something you're going to do when you graduate as your career, but everybody should be educated in this.
Aware of how it can work together with another field,
Yeah.
Or why do I have to do myofunctional therapy?
Do you feel like over the recent years, you've noticed that a lot of conferences you go to that are orthodontic or sleep conferences, myofunctional therapy has been a subject matter a lot more than it used to be?
Oh, a lot more.
Right.
People like you who are educating the masses on this, or Samantha, or the other people that are teaching all over the world now, not just here, but in Brazil and China, and places, Australia. It's starting to blossom everywhere.
We need to be like so happy for that, because it was only a few years ago, maybe 5 years ago, I remember going to conferences and seeing like top sleep doctors lecture and listing different treatment approaches for sleep apnea, and myofunctional therapy wasn't on the list. And I'm sitting there in the audience, like wanting to raise my hand, hello, feeling frustrated and angry. And now I see it on the list in almost every lecture. I actually don't think it's been left off in a lecture that I've seen recently, that like top physicians, at least in the sleep apnea field, are presenting on. It's really an amazing change. It's on the list of treatments.
It's an amazing change, and we all need to keep working on it, not just here, but all over the world. People need this.
Mm-hmm.
It's kind of a movement where people go from unaware to aware. Because like I said, 44 years ago, you did, 2 or 3 months of therapy and that person was good to go, that little guy, But it's different now. It's a lot more complex because, first of all, because of the incorrect treatment that these people have had. A lot of them, I'm seeing now, a lot of the chronic disease patients are young people, teenagers, that have had massive surgeries and massive medications and what I call, misdiagnosis, that nobody's looked at the tongue and what the tongue can do, and the lips. The lips are very important. I had a new patient yesterday who had been in a ski accident and tore her lip really bad. And at the same time, she had 4 bicuspid extraction and 4 wisdom teeth, and she had a small mouth and was maintaining fine. She had had braces because she was a thumb sucker till 11. But her teeth moved a lot with the lip injury. And then she had a small tumor on her palate. It was soft. It wasn't tori. But they took that tumor out and there was a hole in her palate. So they gave her an appliance to wear for a year while the hole filled in. kind of like a cleft palate, like a cleft. And by wearing that thing, her tongue went back to when she was sucking her thumb.
Mm-hmm.
And so she really needs therapy. And I looked at her lips, and even though she had plastic surgery done, it looks crooked.
Mm-hmm.
Because she only slept on her side because she had posterior tongue tie and couldn't sleep on her back. You know, it's the same kind of thing. And she's all excited to get started with this because it's so different. You know,
Yeah.
she's concerned about the way she looks as well as the way she functions. And the orthodontist could not get her bite to be right, you know, because she detected the tongue thrust. So, but she had been maintaining for 55 years. And now it's all coming back because the core issue, the cause, was never looked at.
Mm-hmm. Exactly. The cause is never addressed. And it's interesting that you talked about like the obturator or whatever appliance she had to fill in the hole from the tumor being removed, then cause myofunctional issues to also reoccur. And we see that a lot. Sometimes we think our patients many times are born with dysfunction, but we see a lot of patients who develop dysfunction due to an appliance or due to pain, and they start chewing on the other side and can develop muscle imbalance.
I don't think it really caused it. It's what's happened is the body adapted to the tongue tie and the dysfunction. And it was going along fine. She had no problem. She said, why now? I'm 55 years old. Why now does this happen to me? When, yeah, I sucked my thumb till I was 11, and I wore braces and I had teeth pulled, but I always never had a problem with that. You know, I could sleep most of the time and everything was fine until it wasn't. It's like Humpty Dumpty fell off
the straw that broke the camel's back. Okay, Dr. Mark Cruz, when I saw him present years ago, he had this awesome picture. I need to ask him, like, could I see this again? But it's how he started his presentation. And he had a picture of a guy standing on like a balance ball, like a Bosu ball. And the guy was like balanced even fine. And then next to that picture was maybe it was the same guy, different guy, but anyways, balancing on the Bosu ball, but all crooked, but he was still balanced. And he said, which one is in homeostasis? And we all looked, and he said, the answer is they both are. Just one is compensating to get there. And that never left my mind. That picture and that thought is we can be functioning, but if we're compensating to be functioning in homeostasis, the straw will probably break the camel's back at some point, right? And I just thought that image was really important. And as you're talking about this lady who was maybe struggling, you know, underneath, things put her over the edge. And our patients who have sucked their thumb for years till the age of 11, there was dysfunction there. There was a problem why she was sucking the thumb to begin with that was never addressed. I see, so you let me know if you see this too, but I get so many referrals who have had expansion and like later they've relapsed or whatever, and then they're getting referred for myofunctional therapy without the orthodontist realizing that they needed the expansion because there was a myofunctional issue to begin with. Why are we referring them for myofunctional therapy after they've relapsed or they're on their third expander? Do you get cases like that where it's like the orthodontist sort of gets it, but not fully?
Every day, you know, because the dentists, some of them, they're doing what they were taught in school. You know, when you see this, you do that. But nobody asked the question, why?
Yes.
To get to the core issue of what caused this to begin with. And it's those core issues which I think myofunctional therapists look at least the way I taught you, I know, you look at why did this happen? You know, why? You know, we can fix it, but we got to figure out why, because if we miss one of the whys, we might not. That's why you have to do a complete evaluation. You can't just do a 5-minute zoom.
That's what I agree with. The evaluation is so important, figuring out the why, the underlying cause. And the treatment's usually not that hard. The treatment's pretty easy, but it's the evaluation of figuring out the why. So how would you answer if you have a doctor, a dentist, an orthodontist who does not believe in myofunctional therapy? I've had a case where an orthodontist is like, it's genetic, and didn't want to hear me. So we ended that conversation. But what about when they think malocclusion is genetic and myofunctional therapy is quackery? And how do you approach those situations?
Well, there's a couple things you could do. First of all, leave the research. We have a lot of very good research. Email them. Samantha put a compilation together. We need a new compilation. But also, you can wait for them to have a child, or they themselves or a family member to have a sleep issue that, they'll hear about it from somebody else. You can also, you can't make them wrong. I learned that the hard way. You can't make them wrong. You have to listen. The most important thing you can do with a patient who's in denial or angry is to just listen. And then you write down all your notes, take measurements, and then say, very gently, have you considered function? Actually, there's a new article. Actually, it's a chapter in a pediatric sleep book that 𝐃𝐈𝐒𝐂𝐋𝐀𝐈𝐌𝐄𝐑 is on, and Dr. 𝐃𝐈�𝐂𝐋𝐀𝐈𝐌𝐄𝐑 from Paris, from France, and also Mark, my son Mark, wrote part of it. But it's really good. I don't know if I can share my screen and show you some of the pictures of it. I know you can do.
That's a good question. I'm not sure about sharing the screen on the thing I'm using right now.
I'll send you the article, and
yeah, I'll link it.
It's really good. It's a chapter, but it shows all the functions that are affected by the lips.
Okay.
But you won't believe the lips.
So this would be a good article to share with maybe someone who's doubting or needs more information.
Yeah.
Okay.
But it's the lips and also the genioglossus muscle of all the functions. It's not just tongue thrust.
Okay. And what is this article called? What is the name? Or I can put it, I'll definitely put it in the link. The chapter in the book.
It's a chapter in a book on myofunctional therapy for sleep.
Oh, okay.
Really good.
That's that recent book. It's a hardcover book that 𝐃𝐈𝐒𝐂𝐋𝐀𝐈𝐌𝐄𝐑 we'll
I'm not sure it's that book.
Okay.
Another book that this Dr. 𝐃𝐈𝐒𝐂𝐋𝐀 from Europe.
Dr. 𝐃𝐈𝐒𝐂𝐋𝐀𝐈𝐌𝐄𝐑. Okay. We'll put a link in the notes to that. What about when you get a referral from an orthodontist that you feel like the orthodontic treatment's not really airway focused, but the orthodontist referred the patient to you. So they understand myofunctional therapy, have that relationship, but you can see the treatment is not in line with airway. What do you do? Because I feel like we get this so often.
Uh-huh.
How does Joy Moeller handle that?
Well, all you can do is the best you can do. And with myofunctional therapy by itself, I've managed to get some expansion, which sometimes the dentist will take that. I think I get usually around 3 millimeters of expansion. And the dentist either has to refer for, if it's an adult, for some dental work to fill in the spaces. But it's one thing to send them research, but it's another thing to do a lunch and learn, or just take the doctor out to lunch and talk to him, and keep saying, have you considered, and look at this study, or look at these before and after videos, or dental x-rays kind of thing. They're comfortable with looking at the change. That helps. But sometimes it just takes time. And then there are some orthodontists that don't want to change. They're going to stay doing what they've done their whole life, and nobody's going to stop them. And I've been to the AAO meetings, American Academy of Orthodontics, and showed videos and stuff. And a lot of the doctors change because of that. They see the change, but a lot of them, they don't want to even listen at all. Oh, it's that myo quackery stuff,
Mm-hmm.
They don't understand.
It's funny. There was a doctor here, an orthodontist that retired. So my mentor, Katha Fair, who was here in San Diego for many years, the doctor that was like her biggest referral source retired, and a young guy took over the practice who went to Harvard and, knew so much. And he just thought myofunctional therapy was just.
They're taught that.
What's that?
They're taught that at Harvard.
Yeah.
Nothing to it because it's change. You have to understand, Nicole, people are notoriously resistant to change. And it's one of the biggest blocks for growth. And there was a doctor who wrote a whole book about this. It was really interesting, resistance to change.
Mm-hmm. Well, it was funny because this orthodontist, who's a real smart guy, real firm in his beliefs, Katha brought the binder of before and after photos, went through it with him. And I think he kind of was just like rolled his eyes like, this is ridiculous. But he must have considered, because when she left, he went back through the charts of all the patients that the prior orthodontist had worked with there who had myofunctional therapy. And it was probably the majority. And he looked and he was like blown away when he could see the cases and what happened. And he had her come back, and now he's our biggest referral source.
Mm-hmm.
So it just might take some persistence, pushing through those people who might doubt, showing them photos like what you're saying.
Persistence breaks down resistance.
Ooh, I like that.
Breaks down resistance. It's always that way. And you have to be polite, and you can't like raise your voice, and have you consider, doctor.
I love that. Because it's really non-threatening to say, have you considered? Nobody is going to, it kind of weakens you. You can't come back angry to that.
Some of the doctors are taught, and they feel strongly that if you change the structure, the function will adapt to the structure and everything will be fine forever. But there's a percentage, I say, a lot of my orthodontists feel that way, but there's a percentage, maybe even just 5%, that keep doing the same thing because the muscles are not trained to do it differently. Sometimes it does adapt, and you don't need myofunctional therapy. And you could put in another appliance or a different appliance or something in there to train the tongue, because the tongue wants to do what it wants to do. But when you add the new science on sleep disorders and how myofunctional therapy can help adults 50%, children 62%, it's really worth it to include both the function and the structure. You'll find that your results are much faster and easier and longer lasting. So it's like you have to kind of tiptoe. You got to kind of connect with the doctor the first 5 minutes. Talk about some way you can draw a common thread. And a good way is to just talk about how you're looking for somebody to refer to, because you can't do the structural part.
Mm-hmm.
So,
what about like if you got a referral, maybe a parent just found you online. So they weren't referred by the orthodontist, but they do have an orthodontist. So it wasn't referred by that orthodontist to you, but the parent found you on their own, and you could tell that treatment, like they should be expanding and doing other airway focused treatment. In that case, do you feel comfortable telling the parent and giving them other names of orthodontists, or how do you handle that?
It would be better to talk to the orthodontist first and try to educate them as to why and what you do. And you know, my feeling is all bicuspid extraction is wrong. And they don't understand that yet. They're getting there. There's a lot more articles coming out every day from all over the world. And it's proving that you can do functional changes, combining structure, function together. But they haven't read that yet. So they want to be Dr. God and just be able to do it all, because that's what they're trained to do. So you want to kind of be more friendly with them and just say, well, what about like habit elimination? Like that? They all know that a thumb sucker that's 8, 9, 10 years old, they're going to have trouble. So get your foot in the door, maybe with just looking at habit elimination or habit control, nail biting, you know, mouth breathing. And even though they've had their tonsils out, their adenoids out, and they're still mouth breathing, doctor, what do you do to train them to breathe through their nose? And that seems to help a lot. We talk about how you can assist them in being more successful with things that they know is a problem, like nail biting or thumb sucking and mouth breathing. Even though they've had allergy testing, even though they've had their tonsils and adenoids out, and they're still mouth breathing because it's a habit. So kind of tiptoe around what is the norm for that child.
Making that connection with that orthodontist, even if they didn't refer the patient to you specifically, going to them first, approaching the orthodontist. Have you considered, talking to them? That's a good way to handle it. Because we're all met with these challenges where we see something that maybe we feel the other person doesn't see, and we want to help the patient, but we don't want to offend the orthodontist. And, that's always a dilemma, right?
Go around, because when I first started, every orthodontist thought myofunctional therapy was wrong. Was not necessary. Like the best guy was here in the Palisades. He said, well, 95% of myofunctional disorders will self-correct with structural changes that I make. And I said, oh, you're really a good orthodontist, That's great. That's really good. But maybe I can help you with the 5%, Then when he saw that the people he sent me were so happy, then he started sending more and more and more. So that helped. But then it went the other way, because then he started doing surgery on everybody.
No. Well, what about, we talked a little bit about the ENT issues, and someone has enlarged tonsil adenoids. You can teach about doing nose breathing, but what if you refer a patient to an ENT because you can see those tonsils are huge, or you refer a patient to a doctor for a tongue tie release, and parents go and get a second opinion and they say, no, it's not restricted. How do you handle those situations with the patient? Because we all have that happen as well.
Sometimes I'll say, give a third opinion.
Yeah.
Because you're talking this child's life, its quality of life will be enhanced so much in your opinion. But certainly last week I had a 4-year-old that I've been working on. She would scream in the middle of the night and wake up her parents. And her parents were developing sleep apnea because of the kid waking them up. And the 2-year-old that was a good sleeper was now waking up because the little girl, the 4-year-old, would scream. And she's had expansion. And she's seeing real high quality people. The mother's very, very holistic. But I said, what about the tonsils and adenoids? And the mother said, oh, we're waiting for those to shrink because we did the expander. And I said, and she's been a real good myofunctional patient. So it could be that it's not just the tonsils that you can see that are pretty big, but it could be adenoid tissue. She said, yeah, they're big. I know they're big. And I said, well, in this case, you need to get those out. And she was a very good patient, did all during the day, she's breathing through her nose, but at night she wakes up screaming.
Oh, yeah, because it's going to be worse when she goes to sleep and everything relaxes.
Yeah.
So what did that parent do?
They're going back to the ENT.
Yeah. I feel like a lot of people listen to us as a myofunctional therapist. Once you establish rapport and you educate as to why and the root cause, I mean, I rarely have a case where a parent doesn't listen or an adult patient doesn't listen. So that trust with us is really important, and that could be the key to helping these patients get the care.
And if you sell that to the orthodontist, they're going to listen to me when I tell them that they need expansion. So I'm going to refer that patient to you. If they want Invisalign or they want, braces, I'm going to use you because you're involved in a team approach with me and the ENT and the allergist, as well. So it's all about collaboration. That's why I love the APMD, because it's all about collaborating, because we can't do it all. We can do a big part of it. We can prevent a big part of it by seeing kids younger. But we still need the help of somebody to expand, somebody to check for allergies or for growths or anything abnormal in the mouth. So I think that's critical to have a team of people that you can refer to and that will refer to you. It makes it easier.
For everyone.
Sometimes you get people off the street that come in, and that's harder because then you've got to, say, I think I want you to see this doctor first before we do this. And, we can do that now, but then you're going to need,
Yeah, overwhelming them with all the places they need to go, but it's part of them understanding the big picture.
I think educating, I have lots of books in my office and pictures, and I don't have Better Homes and Gardens here. We don't have that. We have all educational stuff, and I think that helps too. But we're seeing so many people virtually now that they never see all this. But I always use books. I have books here. Why Raise Ugly Kids, Rockabato's book. I have Gasp here. I have Baby Led Weaning here. I have Breath, Patrick McEwen's books. I have all kind of books that I just pull out and say, I didn't say this. Allison Hazelbaker said that she wrote a book on tongue tie and babies, and she's a PhD, so it's not just me, it's the book helping me, or the studies. We send studies to the patients before I see them too, so that helps.
Can you talk about your book that you wrote, a little bit about that?
Well, I wrote a couple of books.
The recent one is
This one is going to be available again soon. It's for children. It's called Tucker the Tongue Finds a Spot.
Mhm.
And hopefully it'll be on Amazon in a month or so. The book I wrote because I would go home at night and feel frustrated. It was good that I'm not a drinker. I would drink because I'd go home so frustrated because I'd see people that have had jaw surgery twice, or, they had their adenoids and tonsils out, but they still mouth breathe because nobody taught them how to breathe through their nose. Or maybe the mother, they walk in with their pouches.
Mhm.
They have open bite on both sides, and I'd be frustrated and go home. And, well, it's organic, the parents would say, and it's easy. My 7-year-old grandson, Nico, he wanted pouches because all the other kids in school were having pouches, and it looked like fun. You just push on it, it tastes good, applesauce or whatever. I'm like, oh. So it was frustrating. So I'd go home and then I'd write a little bit, and I'd write a little bit, and I'd write a little bit. And I'd write my story with my son Brian, and then how I got into it. And I wrote probably half the book. And then I started thinking, I really want this book to get out to more and more people. So I'll ask doctors that I collaborate with to write a chapter. So I have an osteopath that wrote a chapter, a periodontist on periodontal disease. 2 TMJ doctors wrote, one wrote on how to set up a TMJ practice, and the other one was more about neuromuscular stuff. And then I have Patrick McEwen that wrote on a chapter on airway and how to teach breathing. There's a lot of information in the book that would help people that maybe don't have the money to go to a myofunctional therapist. And Barbara Green, who she wrote a nice chapter on how-tos, And so there's a smattering of different people. A sleep medicine doctor who I treated, Denise DeWalt, who
Yep.
I've seen her lecture. She lectured at the IAOM meeting a couple of years ago, and how it helped her. And she's actually got an NIH grant for doing research on the balloon hold, the one that you just put air in and hold it.
Mhm.
And so she's all knee deep in that. And so these are my friends, the osteopath Virginia Johnson, and who was trained by Viola Fryman. And it's all coming together because it's a multidisciplinary. And my friend Shelley Marmette, who was the lady who pioneered and conceptualized the whole field of lactation consulting, and she wrote a beautiful chapter on, the problem with not breastfeeding. It really makes people feel guilty. I told her it's going to make everybody feel guilty, including me. And she said, yeah, but then they're going to go back. And somebody that's just pregnant, you're going to say, you have to read this and you have to breastfeed. Otherwise, you're setting up all kinds of problems.
It's a very, very well-rounded book with all these different contributing authors. And so Is Your Tongue Killing You? That's the name of the book. And
Bill Hang, of course,
yes,
wrote a chapter in there.
So great. And we can get this on Amazon.
Yeah, Amazon. It's also available through the AOMT store.
Okay.
And I think I'm going to give some to Rhonda under Made Easy. She sells kits and stuff. And it's also available on audio on under 50 different sites that a lot of people do audiobooks.
That's where I got it. Actually, I just realized, I'm like, I have it on my Audible. Yeah. When I go running, I can listen.
It's everywhere, and it's in different languages. I know it's being translated. I'm just hoping that people read it and start thinking like me and want a physician. Because until we get a physician that specializes in the disorders of the tongue, no, it's not going to go anywhere. I mean, it'll stay small and people will demand it because they'll read my book or talk to their neighbor or something. But I want the profession to be legitimized, and be available. I mean, if you think of it logically, if they were to do myofunctional therapy in the schools, just have them do 1 or 2 exercises every day before they start class. Do the button pull or take out, whatever, so they can set the stage for a healthy mouth. And healthy mouths make healthy students, make people learn better.
Mm-hmm. Mm-hmm. Well, I'm writing a little children's book right now. It's going to be a series, so that's a lot of work, but it's just in the end phase. So hopefully that'll help with like preschool age population.
Oh, good.
I think a lot of people are doing that. So it's the way to I see a lot of people writing children's books, and the kids will get the kids to listen, get the preschool teachers to start reading these books in circle time, and we'll get this going. I think it's so great. I really thank you for all your time, because I know you spent so much time with me right now, educating everyone. We learned so much about who you are and all that you've done for the field. And I like to kind of summarize things in the end. And we talked a lot about how you wrote the book, Is Your Tongue Killing You? Which is a really interesting concept for us all to think about. Your tongue can also save you, right? So the back of the tongue is a respiratory organ. We talked about it works with the diaphragm. And not only does it help with breathing, but it helps stabilize the body and the brain, that connection to the cranial nerves, which is so important, that tongue being a rudder to the spine, but also helping regulate the body, a regulating system, which can help with so many other disorders. You've seen changes in patients with Tourette's, different movement disorders. You feel that there's an increasing evidence of myofunctional disorders due to many reasons, but one being children, babies aren't breastfed long enough, which is that, catalyst for good muscle development, but we always need to look further. Talked about looking at allergies, other factors. Micro nanoplastics could be a problem. It is a problem. Very scary. So everyone get a glass water bottle. Don't use plastic water bottles. We see there's not just genetic, but epigenetic factors. And maybe some orthodontists aren't aware of that if they're thinking along the only genetic lines. So the ways to connect with our doctors that might be resistant to myofunctional therapy or might not understand that, or Airway, is to try to make the connection. Don't get angry at them. They're just speaking from what they know and what their education is, but using this carrier phrase, which I love, have you considered? Have you considered function? Have you considered is a really beautiful way to open someone's mind to a concept you want them to understand. So we talked about doing lunch and learn, showing them photos of your patients, before and after photos. People generally are resistant to change. My husband will vouch for that when he talks to me about things. I'm like, no, and then I'll listen later. But people are resistant to change, but persistence breaks down resistance. So we don't have to give up as we're kind of opening other people's minds to these concepts. It's okay to tell our patients to get a third opinion if, they found us not through their referral source, but on their own. Getting multiple opinions is okay. Our work is all team approach and collaboration, and that's key. That's the most important aspect. And we also talked about asking why is so important. Our patients are where they are, but we need to ask why and get to the core issue in order to help resolve the problems that they're experiencing. And we also talked about neurology, neuropsychology, neuromuscular. So that tongue position and lips, and what our tongue and lips do for the body is not just muscles and thinking muscles and placement, but the neurological aspect, the endorphins, right? Which is kind of bringing it all back to that beginning part. It's all linked together, and you feel a top-down approach is going to be really important to expand the field. working not from like little components here and there and little courses, but getting myofunctional therapy into the big picture, into like the medical field, making this a requirement or an aspect in every medical type program. So people who are in medical fields and dental and orthodontic fields, even though they might not do myofunctional therapy, they're at least informed about it. Then that can help spread the message, that kind of top-down line of thinking. And I think everybody should get your book, download the Audible version, or go purchase the hard copy, Is Your Tongue Killing You, with all the great different authors who have contributed. It's a really well-rounded concept for everyone. Do you have any last words before we end, Joy?
Yeah. I think it's like whenever there's a problem in your body, there's a solution. And that problem solution thing we need to be part of the solution for many problems related to airway, teeth, and medicine. So.
Thank you. Yes. Thank you for all you do for the field of myofunctional therapy. It's so important. So thank you for being here.
It's all about prevention. That's the key. After treating people with chronic problems that are in their 80s because of this, I feel like it's much easier to treat that 3-year-old, 4-year-old that needs the help.
So true. Early intervention, prevention, early identification. Thank you. Bless your heart for all you do, Joy. I appreciate it.
Nicole, this was great. Thank you.
Take care. Thank you. Thank you so much for joining this episode of Airway Answers. I'm hoping some of your airway questions were answered. Please feel free to give us a rating or a comment. And if you have any further questions, you're welcome to email me at nicole@airwayanswers.info or check out our site at www.airwayanswers.info. Thank you so much and join us for the next one.